Could a better night's sleep start in the dental chair? Welcome back to Dental Talk. Today, we're exploring dental sleep medicine with Dr. Amarjit Rihal. Welcome to Dental Talk, Ami. Happy to have you here.
Great to be here, Gary. Thank you very much.
He's a clinical instructor at the University of Manitoba, and he's passionate about digital dentistry. So sleep dentistry, sleep medicine is a term we're hearing more and more. What does it cover, and why should dentists be concerned about it?
Sure. Well, it's a very large term and broad spanning term. And really what it involves is the clinical diagnosis and management of patients with sleep disorder breathing. Now, really at the start, what's really important to recognize is that as general dentists, we cannot diagnose sleep apnea. So a large part of the diagnostic component of what we do in our practices involve a multidisciplinary team involving ENTs, general dentists, or general medical doctors, as well as sleep physicians as well. You know, from a management perspective, there's lots that we could do in our offices to help facilitate people with these disorders. You know, everything from mandibular advancement appliances, laser therapies, orthodontic intervention with expansion appliances. And basically those strategies are breathing favorable strategies. So really the terminology encompasses dentistry, sleep physiology, and airway anatomy.
Here's what I find fascinating. Patients come in, they have a terrible sleep, and they often don't associate it with clenching or grinding, and they're coming to see you. What are the signs that you're picking up that will give you an indication that something's up?
Well, it's something we see every day, and it's people with an extreme amount of wear on their teeth. And there's usually a multitude of different things that a patient would exhibit that kind of display the fact that they have a breathing disorder or a sleep problem. You know, so extreme amount of wear, scalloped tongues, you know, heavier necks, and snoring. It's a huge thing. You know, people, since I got my Solea laser and, we've had some experiences together with that, they're coming in there to be quieter. And it's typically the partners that drive them into the practice. And we start to go through our analytics with our medical professionals, we can uncover a larger problem. But there's also a large number of interventions that we can do to kind of help these people out for sure.
Yeah, I mean, my awareness was waking up with a sore shoulder every morning because my wife was like poking me as
Yeah.
I was snoring, or
Sure.
a little bit apneic as well. And I started with one of those oral appliances. I tried the CPAP, failed very miserably
Yeah.
with it. Tried an oral appliance, a little bit tender, a little sore in the morning with the oral appliance, but it stopped my snoring.
Yeah.
And but it was uncomfortable. So I came to see you, and we're going to talk about modes of
Sure.
of treatment very, very shortly. But
Yeah.
you probably saved my marriage, I have to tell you.
Well, we're marriage counselors, right? We're keeping people together. You know, the real interesting part about sleep apnea too is that there is a level of diagnostics that really identify a patient population that could be very scary. So 17% of the people with respiratory problems when they're breathing have a central condition, meaning that there isn't actually a physical impediment, but their brain is turning their breathing apparatus off. So this is why we need the medical diagnostics and the proper amount of analytics to really define this population. They need to be on forced air. What we see, though, is that the other 80-something percentile have moderate, could benefit from a CPAP. Compliance is very poor, as you said. You know, it's uncomfortable. And this is where dentistry comes involved, so positional devices, laser treatments, expansion, orthodontic interventions. We can actually not solve the problem, but help benefit better sleep strategies for patients for sure.
Yeah, so you're talking about orthodontics. We're going to sort of segue into kids, and there's a growing awareness that with children that are snoring, that are mouth breathing, that have narrow palates. How do you typically recognize that? And are you treating it yourself, or are you referring out for those?
Typically, for myself personally, I usually rely upon my orthodontic specialists, and we have good relationships with the ones we have in Winnipeg that are very airway conscious. So our hygiene team picks it up. You know, our parents tell us right away that, the child is very hyperactive. You actually look at them, they'll have a physical disposition. They'll have shiners or allergic shiners, it almost looks like. Chronically stuffy, high palates. Tongue ties is another easy identifiable clinical symptom as well, too. So we can actually cherry pick these kids right away and identify the problem before even the parents talk to us. And what's really interesting about children is we can solve their problems. So the rehabs that I've loved doing in dentistry over 30 years, if I had those people as kids, I probably could have prevented that, to a certain degree, prevented those problems in my chair 30 or 40 years later.
Is there a big part with adenoids and tonsils that contribute to the mouth breathing and the snoring of young children?
100%. So any child that is snoring has sleep pathology. So there's no benefit to having adenoids or tonsils. Like in my day, they used to say that tonsils were your first line of an immune response, and unless you're having a series of sore throats, ENTs and general medical people were not really into removing them. Where now the obstructive nature of tonsils or adenoids, are definitely more recognizable, and there's definitely more of an acceptance from the medical professionals to get them out of there. So they understand the importance of the breathing anatomy and apparatus, and even on adults, they've carried them their whole life. So a simple Mallampati classification like snorers, and we talked about your experiences as well too, are typically Mallampati 3-4s. And if you add tonsils into the mix, they're doomed. They're breathing through a straw. So you need to free up the pathway.
So you routinely would send to their
Mhm.
medical practitioner, who would make a referral to an ENT,
That's
ear,
right.
nose, and throat
Yeah.
doctor.
Unfortunately, in dentistry, there's no direct referral to an ENT. But what we find is like when I send a patient back to their MD, I give them my card. And I've actually had a couple of the MDs call and talk to me about their airway complexes and some of the physiological responses that the child are having. Everything from bedwetting, restlessness, all sorts of things. Now, what's interesting about a child is that the longer they stay in those states from not breathing properly, the larger comorbidities that will become permanent in their future adult life. So it's not like a person that's put on a bunch of weight. It's a child that's going to have this impairment that's going to have some really larger detrimental effects later on in
So
adult life.
recognizing it early is
You
the
need to do
key
it.
to the future of that child.
Yeah, and one thing that we also notice that sometimes if you can get that referral in early enough, get those tonsils out early enough, they'll spontaneously correct. You'll see a natural orthodontic as a child is growing, if they're young enough, expansion of their palate on their own. Those posterior crossbites will almost resolve themselves.
Hmm.
The kid will look different every time you see them, and the parents are going to be happier.
That's amazing. Early recognition. Now
100%.
you've been teaching digital technology for years.
Hmm.
What tools are you using, like CBCTs,
Sure.
intraoral scanning, CEFs, to assess the airway risk that a patient has? And how do you show this to your patients?
So there's a multitude of different things you could do, and it's actually quite exciting. So everything from intraoral scanning is a great educational tool, but it's also very qualitative. So we get a real assessment of the transverse relationship of a child, what the vault looks like. We sometimes pair that off with a CBCT, and if you remember when you're in with me, I can actually segment the airway of an individual and then give them a heat map to see if they actually have a physical constriction. So it's very different than the medical CT. They don't have those abilities. So it's actually tuned within dentistry to provide those analytics. I can actually put an orthotic mandibular advancement appliance in their mouth and do another low-level comparison
Hmm.
CBCT to show the volumetric difference of what you're actually gaining by moving the mandible forward.
Very interesting.
On the digital front, some of the level 3 analytics that we use, like the sleep image ring, is a really qualitative little self-study that you could bring into your practice. It pairs up with a sleep physician, so they get your reports, they do your diagnosis, and kind of refer back to you if there is something that's moderate that can be treated with an advancement or a laser therapy.
Yeah, technology is unbelievable.
It is great.
When you look at a patient's airway, whether it's with the CBCT like you did with me,
Uh-huh.
could you assess by looking at that airway what the prognosis would be for that particular patient
Sure.
on a mandibular advancement device? You could say, yes, based on the CBCT, it's going to be successful, or you know what, maybe we need to look at something else.
Yeah, absolutely, you can. So there's basically 4 regions or zones in the airway anatomy that we try to define, being the nasal area, the maxilla, the mandible, and then below. And constrictions that are in the mandibular to lower maxilla area respond very well with a mandibular advancement. And what's nice about them and that analysis of segmentation is I can actually go and divide the cone beam right at the level where the constriction occurs and tell them how many millimeters squared that they're breathing through.
Wow.
And a lot of times, you'll have someone that's like 88 millimeters, and I describe to them that's like something that's 10 millimeters by 8 millimeters. That's your breathing complex, and
Wow.
you see a lot of eyes open up. So the educational value from displaying that to a patient installs a sense of confidence. Their acknowledgement of it's not just a snoring problem that my partner sent me in for. They take it a lot more seriously, and the analytics don't lie.
So CPAPs are really the gold standard, probably the best
Yeah,
thing you could do
sure.
by doing the forced air into a patient that snores or has sleep apnea. But there's a high failure rate with it as well. And I can speak from my own experience. I got a CPAP and I tried it maybe twice. It
Yeah.
was I couldn't deal with it. Who tends to be best with appliance therapy, especially those people that struggle with CPAPs,
hmm
um, but they may be able to use a dental device with a little more
Sure.
success, a little more comfort.
So we rely a lot upon our interprofessional collaboration for diagnostics there. And again, dentistry really needs to be cognizant of the fact that we can't diagnose sleep apnea. So if we go through analytics with the patient, have some survey questions and identify that, there's a larger problem here, we may then take a cone beam, CBCT, segment their airway. If there's a smaller to moderate amount of constriction that's within that mandibular area, they tend to be pretty successful. A large part of what we get back from reports from our medical systems, with sleep physicians, is diagnostic ability, but they also kind of prescribe some treatment alternatives. They'll say that CPAP is beneficial, but may also benefit from a mandibular positional device. So we kind of have a green light,
Hmm.
diagnostically. We're not doing something that's going to be harming the patient. We've kind of carved off to make sure that they're not the 18% central conditions where they stop breathing, which could be dangerous. And those are the ones that we can kind of do some combination therapies with. Oftentimes we get snorers that actually have pretty good airways. So right away, my Slea is the go-to there for treatment. You're going to stiffen up the palate, cause a little bit of expansion or a little bit of contraction, and they're going to quieten down. And they don't really need to have the advancement, and they tend to respond pretty well.
That's great. What's the success on that, on this Alea?
It's physiologically, I would say that everyone that I've done it on has gotten better. So we use like a very simple app that you could download. It's called Snorlab, and it's really qualitative. So what it does is you turn it on. I think I put you through it.
I have it.
You put it beside your bed, and it'll map out your entire night, and then assign a value to how you're snoring. So you can actually see after a Solea treatment the collagen transformation that will occur from the laser energy going through your soft palate into your lamina dura, taking that collagen and tightening it and lifting it. You'll see over a 26-day period a changing of how loud people are. So and you can kind of quantify, is this successful? Now, I would say on some, the effect of that laser treatment in particular will last about 1.5 to 2 years. And we haven't really been doing a ton of redos. I've had the machine for more than 2 years. So, and we do monitor every time they come in for their hygiene appointments. Hey, how loud have you been? How are your numbers? And they kind of report back. So I think it has a really good success rate. Again, the efficiencies of all these systems, sleep hygiene is a multifactorial deal. So you try to promote healthy lifestyles, slimming down, getting that neck a little skinnier. No more chicken wings and beer in bed.
Darn.
You have to have the appropriate amount of self care in order to have better sleep hygiene.
Alcohol does it
It's a
too.
huge thing.
Sleeping pills does it too. It
Yeah.
relaxes the muscles, and
Sure.
patients will snore more.
Yeah.
Getting back to your narrative about Snorlab. Snorlab's amazing, and I got
Yeah.
to tell you, when I first used it, it was frightening what my numbers were,
Yeah.
and I was listening to the way I snore. It was like, oh my goodness, is that me? And since I've had the laser therapy, rather than have numbers of over 25, 47, 50, 60, they're now like 17, 16,
Yeah.
on a regular basis.
Basis.
Now, for a general dentist who wants to start
Yeah.
incorporating sleep dentistry into their protocol, what's the practical workflow? What are the questions that they need to ask? What are they looking for?
Mhm.
And when do they decide that the patient needs to go for a sleep study?
Sure. So it's very simple questions, and what we've done is we've adopted them into our general health questionnaires. So very, very easy questions to begin that conversation are: do you snore? Has anyone told you that you gasp when you're sleeping for breath?
Mm-hmm.
Do you feel sleepy during the day? We identify some early questions. We as part of our clinical examination, we look at the throats, obviously, and we get a little bit of a Malipati classification. We look for scallop tongues. So we do all the diagnostic clinical evaluations. If we see signs, it'll sometimes promote that conversation. Stop bang surveys as well. You can put that right into your health questionnaire.
Explain that. What is the stop bang?
So basically, it's a measure of someone's disposition towards having sleep apnea. If they're displaying signs of an upper respiratory problem or some pathology there. So it's a series of yes/no questions. If you answer yes for a certain number of them, then you have moderate or potential for moderate to severe sleep apnea. So that might look for further testing. I think if someone identifies and kind of answers yes to a lot of questions, we may then proceed to the cone beam analysis. And if they're fairly constricted at that point in time, I may refer them out to a sleep specialist at that time just to make sure that they don't have something that's underlying. What we sometimes do and what we find with patients coming into our offices is they've had that workup already, but they're not CPAP compliant, or they've had some sleep tests done in the past and they're still kind of loud, you know? So we can kind of reinvigorate that analytic. So we do rely upon our sleep physicians for sure. Nice thing about it now is that there's a lot of private health clinics or medical clinics that just deal with sleep dentistry. And it's funny enough, they're using the same analytics. They're using rings as level 3s, and they're using SnoreLab for kind of quantifying how loud people are.
Interesting.
So
Interesting. All right. Quick answers. This is the
Sure.
lightning round.
all right,
All right. You have to answer, don't even think about it. Who suffers more from snoring? The snorer or their partner?
partner,
Partner. Patient's favorite excuse. I forgot to wear it or it's uncomfortable.
uncomfortable,
Change your practice more. Intraoral scanner or CBCT?
scanning, hands down,
Same day crown, CAD cam or send it to the lab?
CAD-CAM 100%.
Are you a morning person or a night owl?
Yes, if I had my way, I would get up early, I would have a great lunch, and then I would like to take a nap, and then I would stay awake most of the night.
Okay. Yeah, I'm more of a morning person. I get up at 4:30 in the morning.
Well, it's ironic. I'm here. I don't sleep well, and I need to find a sleep dentist.
Oh, you do? Okay.
Yeah.
I guess you can't do it on your own.
Not yet.
Ami, thank you. What's clear is that dental sleep medicine touches so much more than just sleep apnea, from bruxism to airway issues to whole body health. We as dental professionals are uniquely positioned to catch these problems early and get patients the help that they need. Join us next time on Dental Talk. Until then, sweet dreams.